yeah, please let me know if the technology goes awry. So my name's Alex, and I'm going to talk to you all today about how to excel in your OSCEs. So a bit about me. I'm not sure how much you heard of mine and Jessen's chat before the official start. I didn't realize that was being broadcast. But anyway, I did a biochemistry undergraduate degree back in the day. It's not been particularly useful clinically, but there you go. And then I did graduate medicine. I did an AFP, and then I did an F3 and F4 where I kind of mixed locuming on mostly gen med / Jerry / COVID wards, and then worked as a clinical teaching fellow, which I would recommend. And I did my postgraduate certificate and then postgraduate diploma in clinical education. And now I'm a public health trainee. So I'm out of the hospital at the moment. So yeah, I'm really enjoying it. And public health's great. And then I also, as Jessen said, wrote some of the questions for the app, and I've also been an examiner in quite a few OSCEs now. So just a disclaimer, what I'm saying here is sort of, please use it in a tailored way specific to your own medical school. Because, this is just my thoughts based on what I've seen before, my own writing of questions and things, but like these thoughts aren't affiliated with a particular medical school, and actually everyone's medical schools are going to be quite different, I would say, in how OSCEs and things are delivered. So make sure that you know what is going on specifically with your own school. So that's a definite top tip anyway. Make sure you know what's happening in your own medical school. But yeah, this is just my slant on OSCEs in general. Okay, so this evening, what I wanted to talk about was what to expect generally in your OSCEs. Then we're going to talk a bit specifically about feeling anxious, and then some kind of top tips before you enter the room, when you're in the room, and once you've left the room, how to prepare generally, some different types of station top tips, a bit about an examiner's kind of perspective and what examiners go through and things. And then hopefully we'll have time as well for some example scenarios and some questions at the end. Okay, so again, just to, repeat myself a bit, but like this is all going to be a bit medical school dependent, these next couple of slides, but I just wanted to give you all a general overview of what you could expect in your OSCEs, depending on how far through the curriculum you are. And kind of, I guess it's pretty sensible that the OSCEs are going to get more difficult and more complex as you go through the school. But actually, a lot more is going to be expected from you as you go up as well. So, in your examination, in your PACES exam, if you're missing a sign, that's not very good. But if you miss a sign on the hands in your finals, that's probably okay. If you miss a sign on the hand in, early on, that's actually, it's not too much of a worry. But yeah, I kind of split OSCEs up into 5 broad categories. Oops. There we go. History taking, examinations, clinical skills, communication stations, and emergencies. And actually, again, this is going to be medical school specific, but you're probably going to find that the makeup of your OSCEs is going to change as you move through the years. So, for example, there's a a fair emphasis on examination skills as you learn them, which is often earlier on in the course, and clinical skills. But then as you get further along in finals, actually the emphasis is probably slightly less, because what the med school really wants to test is, are you going to be a good and competent F1? So they're going to really try and emphasize things like communication stations, emergency stations. So just have a think about where you are in your program, and that's how you're going to emphasize these things in your revision. Because, actually medical schools only get a limited number of OSCEs, and OSCEs are really expensive to run compared to written tests. So they're going to really think hard about the kind of material that they're going to test you on. So actually, is it likely that you're going to get a stats question in your OSCEs? Probably not. Actually the most efficient way of examining those kind of questions is written things. Think about, the types of material where it's going to be most efficient to examine you in an OSCE format. And that's the kind of thing you're going to want to start revising for OSCEs. Okay, so I kind of wanted to just start off straight away by talking a little bit about feeling anxious in the context of OSCEs, because actually, OSCEs are very anxiety producing examinations. And the best possible kind of thing to reduce that, if you're feeling anxious specifically about your OSCEs, is to try and practice beforehand. And the more stressful this practice environment can be, the better, actually. And there's been some studies where you take in groups of medical students and you force them to do a practice OSCE in really high stakes, stressful situations. And actually those students tend to do better in the long term, because they learn that material better after a high stress situation, and they can then perform it better in their exams afterwards. So I would really recommend, although it's uncomfortable to do and to hear, the more you can practice these OSCEs in a kind of awkward environment, the more likely it is that actually the exams are going to be less anxiety producing for you. So I think most people, when they think about anxiety and performance, they think about the Yerkes Dodson law, which you guys might recognize. So it's this, oh, here we go. It's this graph here where as your arousal increases, you kind of hit a performance sweet spot, especially in difficult tasks, which an OSCE very much is. And oops, sorry. Here we go. And actually, so most people are not going to have any problems with having slightly increased arousal during their OSCE end of year exams, but we want to avoid getting into this high zone. So yeah, so the more you practice, the easier OSCEs will be and the less anxious you'll be. So that's kind of the main take home point. But actually, just more broadly, I wanted to take a moment to talk about anxiety in medical school, just full stop, if that's okay. Because, anxiety is related to worsening memory function and cognitive functions, and it can contribute to worse performance. And actually, it's very common for people to feel anxious in medical school. And actually, I think you would be in the minority if you didn't go and see your student support services at some point during your medical career. And there's been some studies that showed, pre-pandemic, around kind of 25 to 30% of medical students experience some form of depressive episodes. And then but that's pre-pandemic. So post-pandemic, things are only kind of going to get worse, unfortunately. And there's been a big study in America recently where they surveyed almost 50,000 students, and 40% of them screened positive for general anxiety disorder. So if you are feeling anxious, there's lots of reasons why you would be. It's really important to seek support and try and get help. So I've left some links and things in the notes of my presentation, but speak to your personal tutor, go to your student support services, speak to your GP, register with your GP. And the BMA have got some really good counselling services that aren't just for members, they're for all medical students and for all doctors. Obviously, there's the Samaritans, and if you're feeling like your mental health is suffering, then it's always worth speaking to the GMC earlier, sooner rather than later. But yeah, so I think it's just really important to kind of put that out there. I know it's not really directly related to OSCEs, but anxiety is going to kind of worsen your performance at med school, full stop. So please go and seek support if you need it. Okay, so now we're just going to talk about before, during, and after a station, kind of my top tips. So before you go in, first thing is to please actually read the question, because unfortunately it happens fairly frequently where students come in and they jump straight into the station that they think they're going, and they've actually missed something. So one of the common things is on an emergency station, for example, where you're actually been asked to do a history and an examination. People just run and jump straight into their A to E or something, and they've missed out a load of marks. So yeah, first off is please read the question carefully. And then also you'll know a bit more about how much there is to do and how you might need to structure your time. And then this kind of second part about reading the question carefully is make sure you kind of start to think about what could be coming up in the station. So for example, where is the station set? Is it in GP? So what kind of things will I have access to? Where will my seniors be? What type of patients are it going to be? What kind of conditions am I thinking about? That's all you're going to try and think about, all these things in that first minute before you actually have to go into the station, and that's going to really help. And actually, although these demographic things are sometimes a bit of a cliche, think about the demographics of the patient. How old are they? What's their sex? What things do you definitely need to rule out? And can you think of anything before you even enter the room? So, and that's going to get you in the right kind of headspace before going into the station. So I know it's a bit of a cliche, but we're going to have a little bit of a demographic cliche quiz, if that's okay. Just to kind of get you to start to think, what are the things that I really, really need to rule out in this station if I sort of read this in the kind of question outside the room? Okay, I'm not sure I can see the chat, but please write your answers in the chat if you can. So first of all, if you had a 19-year-old woman experiencing right or left, for that matter, lower quadrant abdominal pain, what thing do you immediately think, oh, okay, it could be a lot of things here, but what do I definitely need to rule out?
So in the chat, we've got a lot of ectopic pregnancy.
Awesome. Excellent. Okay, good. So yeah, so we're immediately thinking ectopic pregnancy. That's perfect. What about this next one? 22-year-old woman back from a long haul flight. She's on the combined oral contraceptive, and she's presenting with the swollen calf. What are we thinking there?
A lot of DVTs in the chat.
Great. Good. So you guys already, like, you're thinking along the absolute right lines here, so that's really good. This is a massive cliche, but a 55-year-old businessman returning from Thailand. So automatically you're thinking, well, you know, you're possibly thinking STI. What if he had an ulcer on his penis, particularly if that was painless? What are we thinking?
We've got syphilis, herpes.
Yeah, good. So yeah, so good. So if it was painless, we'd be thinking syphilis, but yeah, just generally we're thinking STIs, 55-year-old quote unquote businessmen returning from Thailand. The last one, so a 17-year-old boy, sudden severe testicular pain. What we've absolutely got to rule out.
Testicular torsion seems to be the one in the chat.
Great, cool, good work. So there's a lot of these cliches. So apologies. Here we go. Here's some more. We've got a 25-year-old cricketer who has hit his head with a cricket ball. He was initially fine, but then he collapsed a few hours later. So he's had a something interval.
We've got subdural hematoma, extradural hematoma. I think majority going for subdural or epidural. So
okay, yeah, good. So because this person has a lucid interval, we're thinking more likely to be an epidural, but it's good. We're thinking head injuries. That's the main thing. What we need to importantly rule out. 13-year-old obese boy with a limp and hip pain.
A lot of Sufis coming in.
Good, yeah, so exactly. So we're thinking slipped capital epiphysis. This one's quite hard, I think. So, but like, again, if you had a 28-year-old obese woman with a generalized throbbing headache, there's lots of things that it could possibly be, but what's an important one which we want to definitely rule out?
We've got a lot of ICP.
Yeah, good. So yeah, so idiopathic intracranial hypertension. Yeah, nice one. Or raised intracranial pressure. And then this one, the 65-year-old 1 day post left total hip replacement with respiratory depression. Absolutely classic emergency OSCE station.
A bit of a varied. We've got opiates, fat embolus, vagus nerve damage, sepsis.
Okay, great. So yeah, okay. So everyone's thinking about some really good differentials. I think the thing that kind of stood out for me when I was thinking about this one was their 1 day post-op. They've got respiratory depression. I'm really worried about, well, respiratory depression, I'm worried about opiate overdose, but especially if they're post-op. You don't know how experienced or how naive the patient's going to be with opiates. Definitely remember to check this patient's eyelids when you're examining them. Okay, good. Pupils rather, not eyelids. Okay, so this is the last page. So we've got a 5-year-old with a headache, photophobia, neck stiffness, and purpuric rash.
Meningitis is what it's consensus.
Good. So yeah, so this is meningococcal septicemia that we're definitely wanting to rule out. And then a 65-year-old man with sudden onset back pain who feels faint.
We've got AAA.
Yeah, excellent. You guys are getting it. This is really good. And then a 46-year-old alcoholic with severe epigastric pain and vomiting. He's got smashed.
We've got pancreatitis, gastroenteritis, varices.
Yeah, good. So I guess the varices one depends on the content of the vomit. So yeah, very good. I was thinking about pancreatitis when I wrote that, but yeah, definitely would want to rule out varices too. It's really good. And finally, this is the last one, a 35-year-old woman who is experiencing a headache that she describes as like being hit over the head with a baseball bat.
SAH, subarachnoid hemorrhages.
Yes, awesome. Okay, really good, guys. So that's kind of like I know some of them were like super cliche, but it's important to kind of go through this thought process during your OSCE. And if you're doing it beforehand, then you're making it a lot easier for yourself before you even go in. Because also, if you're thinking about these differentials, you're then going to think about, what kind of questions do I need to ask in my history to rule this in or out? What kind of clinical signs am I going to be looking for? So yeah, so that's going to be really helpful. And you guys are already thinking about the conditions, so you're already most of the way there. So it's really good. So, oops, there we go. Right. So this was a quote from a paper which videotaped medical students going through their OSCEs, and this was the kind of what they said about when people were entering the room. So they pulled back the curtain and then they introduce themselves. Great, tick, always important, can probably get you a mark. And they applied hand sanitizer. So great. So it's kind of a ritualistic start, but it's really good. You know, you're picking up marks straight away from the door. You don't necessarily need to like super exaggerate the hand washing to examiners. You know, I've seen some really impressively large hand washing motions, but yeah, that's all fine. It's really good to make sure you get that mark. But then this last bit I was going to pick up on and say, actually, there's always a danger when there's like the third person in the room, the simulated patient, that actually people are going to be focusing in on the examiner when they enter the room. And actually, you know, you need to be polite and introduce yourself, but you need to introduce yourself to both of them. And you need to make eye contact with both of them and smile at both of them, because actually, ultimately, usually both of them will either directly or indirectly have a say on how well you do. So yeah, it's important to not just ignore the patient or the simulated patient. Okay. So during the station, there's a few kind of things I wanted to mention. So it's important to be systematic, but don't kind of just switch off and go into autopilot, because you're going to have to be thinking through what are your differentials, what's your likely, you know, how does this change the questions I'm going to ask, all these things. There's going to probably be like a little twist to the station, you know, can you anticipate that as you're going along? Don't just switch off and go through your like history structure without thinking first, because it comes across as a bit like odd, and it does come across as like you're in autopilot. So, and there's some really good quotes in which I'm hopefully is going to be in your notes about that study where they videoed students, but I'm not going to go into that now. But yeah, the other thing that's going to really impress examiners is structure. So especially in structuring your answers. And I've got a few examples of structures that you could use here. I always used to think about my examinations in the bedside bloods, images, special tests structure. And I seen that Yasin's actually had got a BBBII in one of his talks on YouTube before. So yeah, background bedside bloods, images, invasive tests. So that's a good way to structure your investigations. There are lots of others. I quite like this boxed one because it includes an escalation plan and the DNA R, which are often kind of forgotten about. But then, there's lots of structure. If you show that you're using a structure, either systems in your differentials, or if you're using a surgical sieve, it really helps to reassure the examiner that actually, oh, okay, this person is really thinking things through. They're going through it systematically. They're not likely to miss anything. I would feel safe with this kind of candidate. And then also, if you're answering anatomy questions, how are you going to structure it? Like, forms of bowel, types of bowel obstruction. You could structure external, wall, internal, things like that. All these things are impressive to examiners because it shows that you're thinking in a kind of clear, systematic way. And that means that you're likely to get all the points. And you're not likely to kind of miss out a big gap. Like, oh yeah, they've missed out all the, you're unlikely to go through something systematically and miss out a whole system's worth of things because you're thinking like, oh wait, I've done this one and this one and this one. And yeah, you're likely therefore to be a safe practitioner. So I think that's really important. So if you can use structure in your exam, then please do. But with the caveat of don't just go straight into autopilot and try and think about these things as you go through them. Okay. Yeah, so this is something that you do sometimes hear about. So make sure that you can perform any of the optional extras that you kind of mentioned. So, in an abdominal examination, for example, you might say, oh, and to complete it, my examination, I'd examine the external genitalia and I do a PR. You're probably quite safe saying that. But if you said, in an MSK exam, oh, and I'd really like to measure the real and apparent leg lengths. What are you going to do if the examiner is like, okay, cool, great, here's the measuring tape. Do you remember that it's the apparent leg length is measured from the umbilicus and the real leg length is measured from the anterior superior iliac spine? I think that's right. Could you actually do that? What you're suggesting, like, oh, in an ideal world, I'll do this, but like, can you actually? So it's really important to make sure that you are prepared to perform these optional extras. Okay. Another one might be like peripheral pulses. So you say, oh yeah, no, to complete my general examination, I want to do the pulses, because actually it's quite reasonable for then an examiner sometimes to turn around and say, oh, okay, great, thanks, we've got some time. And make sure you know where, so that's a top tip then, to make sure you know where the pulses are. Actually, how do you palpate for the tibialis posterior, for example? Because I think even in the real world, you get a lot of doctors being like, yes, I'm examining I can totally palpate, because they're not quite sure whether it's superior or inferior, best felt to the medial malleolus. You usually feel it posterior and superior. But yeah, so actually being slipped with these optional extras is really going to help, and it's not going to throw you if there's kind of this kind of curveball that says, actually, please do that thing that you mentioned. Okay. Here we go. So this was something that was picked up in one of the papers, so called What Influences OSCE Performance, the student perspective. And this is something that students said that really influenced their performance negatively, which was hearing other students do their exams, and seeing kind of simulated patients that they've met before, and it being like a kind of odd situation. So we're going to talk about simulated patients in a bit, but hopefully the COVID secure OSCEs mean that you're a bit more spread out as you do them now. But one thing to reduce the likelihood of you overhearing other students is to make sure that you're talking. And actually, that's another really helpful thing for the examiner, is if a student is narrating what they say as they go along. Because then you can kind of see what they're thinking again, and it makes you appreciate that they are a safe practitioner if they're talking things through out loud and logically. So that would be my top tip, to try and avoid overhearing others. You're bound to encounter curveballs at some point in your OSCE career. So this is from that same paper, where a student's not really adapted very well to a curveball, where they've been asked to certify a death. Dear sir, I'm a medical student, and I hope you don't mind if I could gain your permission to confirm that your life is extinct. You're just relying on your kind of pro formas, and you're not adapting them to the scenario. And one way that some of my friends tried to prepare for this in medical school was to think up kind of non-existent diseases, and then to try and examine themselves on them, which sounds a bit kind of strange, but that actually really does help you prepare to like and think on your feet for these curveballs. So for example, you know, let's say you're asked to see a 64-year-old man in heme clinic that the GP suspects has disease X, and you've got absolutely no clue what disease X is. And so likelihood is, if you haven't practiced something like this before, you're going to go into the station really panicking. But actually, most of the time, you'll be able to pick up a lot of the marks just by going through the basics. So you'll be able to do a really solid history, asking your open questions, picking up on what the patient says, going in on the timeline of the problem of disease X. You're going to be asking specific hematology questions as well that you can think off the top of your head, like what about easy bruising, what about infections, what about any bleeding. You're going to be covering all the bases, even though you've got no clue what's going on. And so you're really helping yourself by just kind of thinking logically. It's like, okay, I'm just going to fall back now on what I can just like think about all these basics that I know about just any hematology case. And then if it was like, oh, what are the investigations that you want to do? You can, again, you fall back on your structure, fall back on the basics. So if from the history, it turned out that the patient had shortness of breath, you'd be like, okay, well, I'm going to do a sputum swab if I can. I might do some spirometry or peak flow, keeping it bedside. I'm going to do some bloods. I'm going to include some hematology specific bloods, FBC. I'm going to do my clotting, ESR, INR, group and save. I'm going to might think about doing some biopsies. I'm going to do a chest X-ray. You can get quite a lot of things, and you still have got no clue what's going on. And same with the management. It's you've heard some symptoms from the history. You think, okay, they were short of breath, so I might need to give them oxygen. We might need to think about nebulizers if they're wheezy. Were they in pain? We're going to give them some analgesia. We're going to go up the WHO pain ladder. I'm going to speak to my senior about this. We might have to discuss their case in the MDT depending on the biopsy results. This is affecting their quality of life. I'm going to talk to the OT and physio about them. Actually, and you've still got no idea what it is, but you've really the examiner can see that you've made a sensible kind of decisions all the way through, and you're still like ticking lots of boxes. And so you would have known all of that about generic hematology things before going in. So like the trick is to kind of practice these kind of unknown situations, and you'll be surprised with how much you can actually get from them. And even if it's a super niche syndrome or something, actually, you're not gonna be expected, this isn't PACEs, you're not gonna be expected to know all the really niche minutiae around these things. And actually, you're gonna be judged on whether you get the like solid basic things right. And so like actually the trick is, again, not to panic and to just fall back on the knowledge that you definitely already have. Okay, so so this is just a side about, again, not panicking. My friend Nathan Spence, I don't know if you're into TikTok, but he's kind of a big guy out there in the TikTok game. And he was telling me that he examined some OSCEs recently, and actually a student just kind of absolutely couldn't perform because they were so starstruck. And there's going to be some curveballs like this. Don't let yourself be put off. Don't like just panic and do something that you wouldn't actually normally do in real life. So, for example, when I was at medical school, I heard of a student who hadn't used the tuning fork before in their OSCE, and it came up in the OSCE. They didn't really know how to start it vibrating. They got really flustered and panicked, and they ended up hitting the simulated patient in the head with the tuning fork to start it going. Like, just avoid that. And that's just a moment of madness. And it's the more you practice under these intense pressured scenarios, the less likely you are to do something like that in the exam. Also, top tip for tuning forks, it's definitely not above a medical school to put out some different hertz or different frequencies, different size tuning forks, and make you choose between them. So make sure that you know which frequency of tuning fork you need for which exam. Okay, so if you're doing a Rinne's or a Weber's, you usually use a 512 hertz fork, and if you're doing a vibrational sense one, then you're going to use an 128, generally rule of thumb. So, and it says on the little kind of circle bit at the top of or like here, I don't know if you can see my mouse, but it usually says here on the tuning fork. Okay, that's just an aside. So picking up on cues. So this is the next thing I wanted to mention. A lot of the time, people will, understandably look at the examiner trying to kind of read their expression and try and pick up on cues that they, whether they're doing well or whether they made a mistake, and actually ultimately try not to waste precious moments in the exam by doing this, because examiners can't influence student behavior. And I was really racking my brain as I was writing this to think about any kind of scenario where an examiner might kind of even subconsciously influence student behavior. And I actually couldn't really think of any, unless it was like a student had gone completely panicked and wasn't doing anything, and they might repeat the question for them or something. But I really was struggling, and then that got me thinking about, please don't be someone who refuses to do something in the exam. So there's panicking, and then there's also panicking and just refusing to do anything, which is also, it never bodes well, because you're not going to pick up any marks. And this can sometimes happen if, you know, people think that if they did something, it would be quote unquote unsafe. Okay, so for example, I was trying to think of a scenario where this would happen, but if you had to prescribe something that you weren't comfortable, you didn't know how to do, like a fancy antibiotic, like a vancomycin, or you were prescribing blood or something like that you'd never done before. So definitely, it's always the right thing to say, you know, I would ask my senior how to do this because I'm not quite sure, if you're not sure, you know, because that signposts really clearly to the examiner that you are safe. Okay, but try and not then just be like, well, that's it, sorry, that I'm just going to have to sit here this station. Okay, because, you know, the examiner can't give you any marks then. Much better to be like, okay, you know, I actually don't know I'm not quite sure how to prescribe this, so in real life I would ask a senior, you know, but because this is an OSCE, I'm going to now proceed as best as I can. Okay, you go ahead, you prescribe the vancomycin, and then again you're saying, you know, I'm not sure this is right, I would check this with my senior before, and the pharmacist, before I gave it to showed it to a nurse for them to administer. Okay, and then at least you've had a go at kind of picking up some marks during the station, and you've made it completely clear that you're acting in a safe way. Okay, don't fall into that trap of just thinking that you have to not do something. Okay, in order to stay safe. I mean, it's really tricky if you actually have no idea, but like actually just say, I'm not sure. In real life, I'd ask, I'm going to have a go now. And then at least you can try and pick up some marks. Okay. So that's kind of the during section. And now after the OSCE, it's very common to kind of like think back about what you've just done in the station, be like, oh, I missed this, or I didn't do that very well. And, you know, that happens to everyone, but it's really important to try and just, you know, it's done. You've got more OSCEs to do, just drop it. And sometimes that's easier said than done. And actually, hopefully this is reassuring that in terms of subjectively assessing OSCEs, actually, we're not very good at predicting our performance afterwards. So, you know, just let it get out of your mind, because you can't allow it to work yourself up to the next station. So I remember in one of my OSCEs, one of the candidates on my circulation, like my kind of rotation, came out of the station, and honestly it looked like something from a horror movie, because he was covered in red kind of ink, like, which was the you know, pretend blood, and absolutely covered head to toe in his like newly ironed crisp white shirt. It was like all in his hair and in his eyes, and like people were like hurrying to get him tissues, and he looked absolutely distraught. And you just knew that that was going to rock him for the rest of his stations. But like really, and this can happen, unfortunately. Like there's a malfunction. You know, I've seen when I was doing like an F2 simulation day, the like piping for the mannequin went wrong, and we were all covered in like fake urine, and it was just all terrible. But actually, you know, in an exam, you've just got to try and shake it off as best you can, and not let it affect your next few stations. Because the problem is which does happen, when students come in and they're already on the verge of or in tears, the sad truth is that usually these students don't perform to their best in the exam. So try and keep a level head and, you know, plow on as best you can. And once the station's done, it's done. I know it's easier said than done, but you're only going to be losing marks that actually you could get if you just took that second to be like, it's okay, that's just one station. I've got the whole rest to go. I can pull this out. Okay. So in terms of preparation, specific OSCE preparation is key. So download the app and get your friends together and actually revise specifically for OSCE, because interestingly, it doesn't really correlate to how well you do in other exams, OSCE performance. So don't just think, I absolutely smashed my written exams, I'm just going to like give a cursory look over my OSCEs, because actually, you know, they deserve their own kind of revision schedule in their own right. Okay. I mean, obviously I'm going to say that in this talk, but it is true. Okay. So, I mean, my actual tip is to just straight up practice. If you can develop your own station, use the material that you have around you, use the app, the Quesmed app. But, you know, just try and practice as much as you can doing OSCEs. You know, go to the wards, practice on patients, practice with others, and just practice over and over again. So things like examinations and clinical skills are just become second nature. Okay, and you don't have to worry about the minutiae of the techniques and things, and you can be going and thinking about like, okay, what's the differential diagnosis? Like, what do I definitely not want to miss in this exam? Like, what do I normally forget? You have that room in your head to think about these things as you go through, because you're like so well practiced. That's the stage that you want to be at. Okay. And like, this is a bit of a rant from me, because like I always go on about this. And you know, my personal tutees were sick of me saying this by the end of last year. But actually, you know, medicine should be learnt as a team. And like, the more that you work with others in your revision, especially for OSCEs, the like easier things will become. Okay, because like it's much easier to get a consensus about where everyone's at, what material is important, because you can't learn everything. And like, the more you put yourself out there in your practice, the easier the actual exam will be. Okay. And, you know, some people say, you know, oh, but I learn better on my own, or I just want to understand the material first. But actually, you know, when all things said and done, putting yourself out there in an uncomfortable place, you're gonna get to grips with the material and learn things a lot better than if you're just kind of stuck passively on your own, being like, oh, I'm pretty sure I've got this. And like, the more effortful and the more uncomfortable you make your learning, and this is for everything, not just OSCEs, the better you'll do in the long run. The more you engage in your lectures, in your group work, the more you speak up and ask questions, the better you'll do. And that's 100%. The people who are, you know, talk up and do things and get involved on the wards or in, you know, in class and stuff, will always do well, because they've made the effort to get to grips with the material at the time and like go through that difficult process. So that's just a rant essentially, but please do practice with others when you're doing medicine, full stop really, but especially OSCEs. Okay. Oh, yeah, okay. So actually, if you're revising for finals, the GMC also lists 23 things that they expect graduates to be able to do. So that's worth looking up. and it's quite helpful actually. It tells you like what level of depth they want you to learn, but the links in the notes for that. I'm just saw the time and I'm going to try and speed up, but apologies that we're slightly overrunning. Hope that's okay. So this is just like a theme by theme kind of top tips. So we'll just go through this a bit more quickly because I know it is now 7:30. But so do's and don'ts for history taking. So make sure you ask more than one open question, because the candidate, especially if it's a simulated patient, will end up giving you much more information after that second open question. Make sure you use your structures like your Socrates or your Squitas or your pain history structure. Always remember the red flags. Make sure you hit the easy marks, and then the easy marks are going to be your smoking history, and your alcohol history, your social history. Get your smoking in pack years, get your alcohol in units. Make sure you remember ICE. I know it's a cliche, but there's like usually 3 marks for ICE, and try and practice your summaries. And also, that's the whole thing about like being present in the scenario. So try and actually actively listen and not go into autopilot. Some of the common things you see is people asking, 2 questions in one, because they'd be like, oh, and also I've just thought of this. Try and avoid that, because it just like derails the whole conversation and the patient doesn't know which to answer and all these things. So try and make sure that you're super slick in your histories. Don't get blinkered down in one diagnosis. Take a step back. Make sure you've got your systems review. You're happy that you've hit all the bases. Obviously, don't use jargon. Don't forget about allergies, and try and actually address the concerns that you brought up in ICE, even if it's just like I'll see what we can do about that. Just like instead of just being like, okay, and also what's your expectations? Because you want to like actually holistically show that you're thinking and caring about the patient. I know it's hard under time pressure, but like it really makes a difference. Okay, so for examination, like we said before, practice them until you're really slick. Like top tip for neuro and MSK exams is just instead of keep constantly being like, okay, stop me doing this, or resist me, or stop me like pulling you, stop me pushing you, just say, stop me moving you around, and then it'll be like, okay, right. Then you can just actively get on with the examination. Get a chaperone. And explain what you're going to do clearly to the patient before the exam. So it's not good enough to just say, okay, now I'm going to examine you. Is that okay? And then just go straight in for like bilateral chest expansion with no explanation. Yeah, because that's like actually a red flag, because especially if it was a female patient, it's like that's quite an unsettling thing to happen. So make sure you're really clear about make sure you're really clear about what actually you're going through in the examination, because otherwise it's like you might be failing on your global score if you did something like that. And if you've forgotten something and you think halfway through, don't panic, just go back to it. It's okay, don't let it ruin your flow. Don't hurt the patient. So it's important to say, do you have any pain before you lift their shoulder or things like that, before you manipulate them. Don't get stuck on something like, oh, can I hear creps here? And then just spend a whole minute just listening. Just, is it obvious? Yes, no. If it's under time pressure, just keep moving and try not to run out of time. And that'll come with practice. Okay. So clinical skills, again, it's just getting into that routine that you could do with your eyes closed. If you can, go to the clinical skills lab and practice with the equipment that they'll probably then end up using in the OSCEs. and practice talking through what you're doing. Same thing, get informed consent, ask the chaperone. You guys will be really good at this. Like, don't forget the right PPE, because you're always having to put on PPE now. And don't stress if the urine bag breaks or the arm explodes in your face with loads of red ink and all of that. Don't forget to dispose of the sharps, because otherwise the examiner will have to do it afterwards and they'll know that you haven't. And also, don't worry if the equipment's different. So like if you're doing a venipuncture station and your hospital that you trained in has like a different color blood bottles, don't panic. Just say to the examiner, this is different from what I'm used to practicing on. Often they will have like a secret set under the desk or something, but even if they don't, then at least they're aware. So yeah, don't panic, because that's probably something that will get flagged up after the exam. Okay, emergencies. Yeah, this is one of the dangers. Like if you don't read the question fully outside, don't just jump in. If you're given results to interpret, again, try and speak aloud. Make sure so the examiner knows you're safe. Otherwise as well, like it's really awkward if someone sat there in silence interpreting an ABG and then they just say the wrong answer, because then you've got no idea where that came from. And at least if you spoke through the ABG, then the examiner could see where you made the mistake, or you might not make the mistake because you're talking through it logically out loud. So like, because it's really hard to just like, you can't really do anything if you're just given a wrong answer. Whereas at least if you're given a wrong answer, but it's clearly logically explained, they just made you just made a silly mistake, you can be like, oh, well, they don't get the mark there, but globally, the global rating, I'm more impressed with that kind of candidate. So structure your differentials. So make sure that you have your most important differential, the things like we were saying before, like you really desperately need to rule out, like if you think it's appendicitis, but we need to rule out an ectopic pregnancy, for example, and then you're going to do all your other differentials. You might want to group them into system, show your structure. Don't forget about allergies again. Don't skip the basic tests. Okay, yeah, so for example, this can happen if people get overexcited and they think, yes, I've definitely got it. It's definitely PE. I know that we're gold standard. We're going to do a CTPA. Bosh. But actually, you've missed out loads of marks, because what if it wasn't a PE? What if it was a STEMI and you needed to do the ECG? You needed to do, what if it was a pneumonia? You're going to need to do bloods. You're going to need a chest X-ray. And, because actually missing out all those things is like not actually that safe. So don't skip through those basic tests. Always think logically, always have that structure to lean back on, but with an actual thought process of the day about what's happening. Don't forget to reassess. So you've done your A to E, don't forget to go back, reassess. Always looks good. Don't forget about analgesia. And hopefully you wouldn't do this, but sometimes in a panic, people can just guess. And actually, it's another one of those things saying, I don't know. Normally I'd ask a senior, but if I had to, I would say something like, if you're pushed, usually, or sometimes you might have a BNF there. Make sure you know how to look things up in the BNF. You're familiar with it. You can do things you can look things up in the BNF under pressure. Okay, don't write U for units on an insulin prescription, all those kind of things. Like you write units out in full, all of that. Okay. Good. And this is just a list of common emergencies. I won't go through it now because I am aware I'm well over time, so I apologize. But yeah, there's there in the notes for you. But just think, actually, the the medical schools want to test you to make sure that you have a really firm grip on basics and common things, and you're not going to miss like life-threatening things. That's actually, they want to make sure you'll be a really good F1. Okay, so think about those kind of things that they're going to test you in. It's a lot less likely they're going to test you in something really, really rare and unusual. Okay. Communication, so this is the last station, kind of grouping. Top tip is, start with your open-ended questions, get as much information as you can, and then go straight in for ice, okay? Because often, if it's a communication station, there will be concerns that you have to address, okay? And so the earlier you understand what the concerns are, the more easy the station will become, especially if it's like a bad news or a complaint or something, that kind of a station. Make sure you're actively using your non-verbal communication, you're sat openly with your body posture, you're nodding, you're actively listening, all of that thing. Be holistic. Actually, sometimes in communication stations, there's lots of extra information that, if you're a really good candidate, you'll be able to scoop up a lot of that as well, and you'll introduce that into your conversation. Don't forget to apologize if that's what's required, and don't get too bogged down in the kind of clinical side if that's not what if that's not what the station's about. So remember, that's all again about reading the question outside and trying to understand, okay, this is a communication station. It's about handling a complaint. Don't get bogged down in why they came into hospital. Get bogged down into handling the complaint. Good. So this is a little bit about hawks and doves. This kind of goes both ways. So don't be too scared if you think the examiner is a hawk, and don't be too relaxed if you think they're a dove. Which sounds a bit bizarre, but you can see, you can sometimes see that is that, students might visibly relax. You hear that they were really relaxed because they had a junior doctor who they knew was as their examiner, but actually it's still an exam and you still need to do as best you can. And sometimes you can over relax, going back to the Yerkes-Dodson curve. And actually, don't worry if you think that they're a hawk, because there might not be, and all these things. So, there's some evidence that suggests that the kind of earlier you are in your clinical career, the more of a hawk, secret hawk you actually are. And the later on you are, the more experienced you are, the more of a secret dove you are. But also there's some evidence that suggests that absolutely nothing can predict whether you're a hawk or a dove. So, just try and put that out of your mind. Also, I should just, for some context, hawks are people who examine harshly, and doves are people who examine like, oh yeah, I'm pretty sure they got that type thing. Examine kindly. Okay, and yeah. Also, I guess this is another thing about, don't get too flustered, especially if someone's giving you their like examiner face and you're used to them being super friendly. Don't let that like kind of off-put you. Okay. So this is just a very brief background on examiner training. I don't want to bore you, but hopefully it's quite reassuring that examiners have unconscious bias training. Although obviously that's not foolproof, but that should hopefully be slightly reassuring. Again, hammer that point that examiners are explicitly told they can't give any conscious or can't give hints to candidates. So don't waste your precious moments in the exam trying to look for feedback from the examiner, because they can't give you any. Okay, and yeah, don't be put off by a kind of examiner face. Okay. The third person in the room, so that could be a patient or an actor, simulated patient. So this is just briefly going to talk about them. So often, remember, these actors or simulated patients or patients have a say in the final grade of the OSCE. So it's worth, like we said before, not ignoring them as you walk into the station. And actually, there's some fairly good evidence that these kind of grades given by patients and actors are supplementary to examiner ratings. So you might see that happen more often in more medical schools. So yeah, just heads up, even if they don't get a say, don't treat them differently to the examiner. Be polite to both. And if they do have a say in your grade, what do they actually want? So, they like holistic, person-centered clinicians. I mean, don't we all? It's kind of obvious, I guess, but actually, it really kind of emphasizes the point that rapport is key when you're in your OSCEs, especially when there's a third person in the room, and because that third person does have quite a lot of power. They can help or hinder you, especially in in history or an exam. They can just not offer you up any information. They can not understand your instructions, if you're rude to them. And just make sure, I know that's a high pressure, I know that people are going to be nervous, but make sure that you are polite and friendly to the patients and simulated patients. I know it's really obvious, but actually people forget that in the heat of the moment, and they just kind of treat patients like repositories of information. So try and not do that, because you'll score, one, it'll make you a better doctor in the long run, but two, you'll do better in your OSCEs. Okay, so just wanted to do a tiny bit about marking, but again, with their big caveat that this is going to be different depending on which medical school you go to. But the different types of mark scheme does kind of like, you might need to emphasize different parts of the station as you go about it, or I'll explain more as we go along. But anyway, so this is an example mark sheet, and usually examiners will have these to mark candidates, but often they'll mark candidates in two different ways. So they'll do the marks and they'll do a global assessment as well. So if your medical school does a global assessment too, then actually, be reassured if, for example, you think that you didn't know much about a station and you might have lost lots of marks, but as long as you were safe and logical and reasonable and friendly and competent, all these things, then you'll do better on your global rating. Okay, but similarly, don't just think, I got all the marks for that, but you kind of were a bit abrasive and rude and all those things, then actually, be careful, because the global rating, you're going to do worse. Okay, so make sure you know what your med school does. And then broadly, there's three kind of different approaches to marking. I'm not going to spend long on this, but just be aware like what they are and try and know which one your medical school does, because again, it's helpful like in the way you're thinking about OSCEs. So you've got a borderline regression method. It's basically where you take the global ratings, you map them out with all the marks for each global rating, you stick a line of best fit through, and where that line goes through the borderline candidates is where the pass mark is. Okay, so that means that you could technically fail but get enough marks to pass, and you could technically pass but get only enough marks to fail. You see what I mean? So if you knew that your school was doing this method, then you know that actually like it's worth going all the way to the end of the exam, speaking out loud, trying to hit as many marks as you possibly can. Okay. But again, if you're using so then there's also the modified Angoff, which is where they kind of med schools think up the marks, the pass marks before the exam based on what examiners think people should get. And again, like actually, if there's no global rating here, it's all about getting those marks. Make sure you speak to the end of the station, all these things, you know? So so like really have it in your head how your med school marks your OSCEs. But anyway, that was just an aside really. There's the new exam coming up for finals, which is the clinical professional skills assessment, which will be your OSCE in your final exams. And actually, there's loads of stuff online to help you with this. There's quite a lot of information that the GMC have put out there. The main point I was going to say is that actually, because medical schools said that they felt well prepared to meet the requirements of the CPSA, should be reassuring, okay, because they will be using their own OSCE content for this exam, okay, so hopefully things won't change too much when you do your PSA. In the same breath, the GMC already does some OSCEs, and they're called the PLAB, which is for foreign doctors that come to the UK to practice. This is aimed at F2 level. So just in case the GMC do decide to run the CPSAs after all, this is the kind of example of a GMC OSCE, okay, which I thought you might want to look at. So this is the kind of standard that the GMC think a F2 doctor should be able to like achieve. Okay, so it's not that much higher than finals. You're an F2, you need to speak to a patient, 45-year-old male who's complaining of pain in his head. You must assess and manage over the telephone in 8 minutes. So that's quite tight for time. Okay, so this is probably why it's quite a hard station. But actually, the things that you need to cover to pass the PLAB is the same basic things that we've been talking about the whole way through. So, you know, can you take a history? Can you take a presenting complaint? Can you take a medication history, past medical history, social history? Did you do ICE? And then, you know, did you get the diagnosis that it's migraine? And then you just got to add on the management. Okay, so hopefully, actually, that's not too scary. I've just written a few three example stations, just real quick. If you can hold on that long, I absolutely will not be offended if you can't. I apologize again for running over. But for example, you're an F2 in GP. So already you know where you are, what kind of problems you're going to maybe be dealing with. You've got 10 minutes to talk to Mr. Smith about his blood result. Oh no, he's got a really high HbA1c. Okay, sounds like you're going to be breaking bad news. What mnemonic are you going to use in this station? Feel free to write in the chat.
So we've got spikes.
Yes, awesome. Thank you. Big up the people who are still here. Thank you very much. So yes, spikes, exactly. And spikes is like absolutely bound to be on the mark scheme for a communication skills station. You know, like it's very, very likely. So make sure you do spikes, make sure you know what it is, make sure you do it. Okay. This is like a kind of station that is becoming more fashionable now because it's quite a lot like something an F1 would have to do. So especially like a final station, it is like you're handed over and it's like a prioritization type of station. So you've got 5 patients and you need to prioritize which one you can see first. And actually, you could even add this into a communication type station where you take the handover, you have to ask questions. So this is quite like I think quite a nice kind of OSCE station. So I'm going to give you 30 seconds to have a think about how you would order them, order these patients. and then write it in the chat if you want to. And obviously, full disclaimer, I came up with this, so I'm absolutely happy for people to disagree. There's no official right answer.
So we've got first one first, and then someone else has put 145 T3 or 154 T3.
Okay. Cool.
So 1 is always first, and I think 3 seems to be last. 2 and 3. Yeah.
Okay. Interesting. Yeah. Okay, that's really good. So, I think the point of this station, as well as being able to prioritize, is also to be able to explain it. So I think don't worry as well if you get a station like this and you disagree with someone afterwards and you're like, oh, I said this one and you said that. It's not about that as much. It's more about seeing how you think, making sure you can reason why you're seeing these patients first. But also in the same breath, I'm really glad you all said 1 first. Because patient 1 is really, really unwell, and they sound like they're quite unstable, because we've got something, vomit that looks black and smells weird. Is it coffee ground? Do they have an upper GI bleed? Their blood pressure's dropping. They're not very stable. This is a really unwell patient that definitely we want to be seeing first. I'm really pleased that you guys said that. I then went with patient 5, but again, feel free to disagree, because they also require treatment from you in order to improve how they are, in order to kind of improve them prognostically. They require treatment quite, from you, if that makes sense. Can't really, something for you to do actively. Then I went with 2, because again, it's like a patient that requires active treatment, but this won't affect their prognosis in quite the same way. But I can understand if you disagree with that. The kidney stone patient, definitely in pain, and we can up titrate that analgesia. See them next. And then I went with 4, because actually this is another task where, again, so there's no immediate harm that's going to befall the patient if you're not going to go see them straight away, but actually it's good practice for you to go see them because you want to understand why they want to be discharged. Is it safe for them to do so? You don't really know much about them. Do they have capacity? All these things, like what's going on. And then 3, although it's something really important, it's not life-threatening. It's not prognosis threatening. It's not, they're not in pain. Actually, this discussion can be left to the last one. So that's really good. But again, this is with the big caveat that I wrote that myself, so you can disagree. But this is the kind of station that you might see in your OSCEs. And then final one is you are asked to perform a handover at the end of your A to E. What mnemonic do you use to structure your handover? And what mnemonic is, again, very likely to be in a mark scheme?
So you've got S-bar.
Awesome. Yeah, good. So these kind of spikes, S-bar, some of these mnemonics are likely to be in mark schemes. So make sure that you really know them, okay? Because it's like a gold standard of how to perform these things. So, why wouldn't it be in the mark scheme, actually? Yeah, but really good. So just to conclude, put yourself out there, make your revision uncomfortable, because the more uncomfortable you make it now, the easier it's going to be in the future. Practice specifically for OSCEs, practice with others, practice on the wards, practice in the clinical skills lab. Ultimately, protect your mental health. And when you're actually in the exam, try and use a structured approach, but don't be too prescribed. Don't get those blinkers on, and try and take a step back and be like, how is this structure relevant to this case? Okay. Phew, only ran over by 50% of the time. So I apologize, everyone. Well done to anyone who's still here. And do you guys have any questions? I really like this picture, by the way, Yesen.
So thank you so much, Dr. Alex. So yeah, we've got quite a few questions. So I'm just going to stop recording and then go through them.